Welcome to Fluorescene.
Hello and welcome to the Fluorescene Show, Season 1, Episode 12. I'm your host, Dr. Alan Glazier. Be sure to subscribe to our channel by hitting that red subscribe button just below me for notifications on new shows and segments. Now this week, in Odie's on Facebook, a doc posts this picture and says, retired engineer has done visual fields from home for several years with Microsoft Paint. How about that? He was so sure of his own results, he was reluctant to keep his appointment because he knew it was stable. A doc commented, he's like a walking Goldman visual field. In even weirder news than the engineer in the chair news, a doc post, today I had to do an exam on a man who had viable multiple bugs crawling on his back and clothing. Yuck. And here I was thinking COVID was the only bug to try and avoid. A member commented it reminded her of the fourth year in school when a cockroach came out of a patient's cleavage during slit lamp, then crawled back in. Yes, exam done. Another doc commented, this happened to me during residency. The entire floor was closed the next day for fumigation. But the best comment was, thank you, Jesus, for not letting that happen to me in 43 years of practice. Agreed. A doc posted this image and titled it, A Blast from the Past, a B&L complete lane including unlinked phoropter. One doc commented, why an entire generation thought that avocado was the best color for everything is beyond me. But the winner was, that's the phoropter that prescribed Jan Brady her groovy glasses. A doc posted an amazing image of a patient's internal carotid aneurysm. You can see the ophthalmic artery branching directly off of the aneurysm. Incredible. Loss of that artery would not be good. The surgeon reattached it elsewhere. There's no after pics yet, but a member pointed out, what about Lord Voldemort on the upper artery? Just an incredible image that I wanted to make sure that everyone saw. A doc asked, what's the most clinically useless information that you have to obtain because of state law? And man, what great comments. Unaided VA was a really common one. Family history of cataracts? Yeah. Do you drink alcohol? Yeah, why do they even ask that? Family ocular history of astigmatism? Near point of convergence? And in my opinion, the winner was the drawing tool that's found on most EHRs. Summing it up, a doc posted a quote from the show House. We are condemned to useless labor. Well, we've got a great show for you tonight. Our guests include Dr. Alison Bozung, associate at the Bascom Palmer Eye Institute, Ophthalmic Emergency Department, a popular lecturer and author on ocular disease topics, and Dr. Dan Twelker, OD, PhD, professor of ophthalmology at the University of Arizona Department of Ophthalmology, and principal investigator in the CHAMP myopia study, and the current president of VOSH International. Dr. Judy Hu, glaucoma specialist, returns for the second segment of Who's Got Glaucoma, where she shares a compelling case, including diagnosis and treatment recommendations, and more. So be sure to subscribe by hitting that button down there and enjoy this week's Fluorescene Show.
Hi, today I'm here with Dr. Alison Bozung. Dr. Bozung practices at Bascom Palmer Eye Institute in Miami, Florida, lucky her, primarily in the Ophthalmic Emergency Department. She also serves as co-director of the Optometrist Student Externship Program. Prior to joining Bascom Palmer, she was a clinical assistant professor at the University of Iowa Hospitals and Clinics in the Department of Ophthalmology and Visual Sciences, practicing in the cornea and external disease area, as well as comprehensive ophthalmology services. Dr. Bozung received her Doctor of Optometry degree from the Southern College of Optometry in Memphis, Tennessee. Upon graduation, she completed a residency at the Bascom Palmer Eye Institute, University of Miami Miller School of Medicine. She's a member of the American Academy of Optometry, the American Optometric Association, the Florida Optometric Association as well. Dr. Bozung is a sought-after lecturer and author on ocular disease topics and serves as a co-editor for the Review of Cornea and Contact Lens. So welcome, Dr. B. I'm so happy to have you here. I've been following your career.
Thank you so much for the invite.
Oh, my God. Alice and I last saw each other while lecturing at Tropical CE in St. Kitts, the beautiful St. Kitts. For anybody who hasn't gone on Tropical CE, that's Jill Autry's trip. I strongly recommend it. Not only is it great education from people like Dr. Bozung, but you get to meet great people too, which we did. I remember one thing about the trip. I tried to teach you craps, and I think you had fun. Have you been back to a craps table?
I have not yet, but it's definitely in the works. Once things open up more, I feel like I'll be going back. But I did win $80 that night from your craps lesson. So
you always win the first time, and that's what suckers you into start losing. So maybe COVID was a blessing in disguise. As long as
probably,
I
I feel like on a street corner somewhere, living in a box, probably.
As long as it didn't become a problem for you, and then you were doing online craps. But I was just checking in. Good times. Good times.
Yeah, thanks. Always a good friend.
So can you tell our viewers where you're from, where you went to school, although we said it in the bio, but a little bit about it, and your experience working at the famed University of Iowa Department of Ophthalmology?
Absolutely. So I grew up initially in South Dakota, so I am a Midwesterner at heart and sometimes by accent as well. And I went to school in Nebraska for undergraduate and then went to Memphis, Tennessee, of course, for optometry school. And then after that, again, the bio stated, I went to Bascom Palmer for residency and then was actually kind of landed upon the job at the University of Iowa somewhat serendipitously. So I wasn't trying to get back to the Midwest necessarily. I actually was trying to move out west to like Washington or Oregon. And in that search, I met someone who used to work at the University of Washington, who then worked at the University of Iowa. And it's pretty much one of those small world scenarios where it ended up being that there was no position at the University of Washington, but there was one in Iowa. So I ended up interviewing there and just kind of trying to see what it was all about and fell in love with it. It was a great place to work. I felt super fortunate to have that as my first job out of residency.
It's world famous. When I was working in Israel, the first question that some of the really super famous ophthalmologists asked me over there was like, "Oh, have you ever worked at University of Iowa? In ophthalmology?" And it was the first time I had really been exposed to it. So yeah, very well internationally known as well.
Yeah, absolutely. They've got so many resources. That was, eye rounds is probably the biggest one that people know about, or gonioscopy.org. So they're very, very well known. And without even thinking about it, when you're in school and you're, researching all these things, you're doing residency, you're looking at pictures of different conditions, and you will always come across eye rounds photos, and they're great photos. So I think that's where the name kind of extends out quite a bit as well.
Right. Absolutely. Now, from what I heard, and you tell us if this is true, that something about if cows didn't have eyes, you might have never been an optometrist. What's that about?
Yes, that's actually true. Did I tell at some point?
What's that?
I don't know if I don't remember telling you that part, but
oh, I did my homework. I do my homework for
I
these.
see that. I'm a little bit scared about what's going to come up later in the interview. But no, that's definitely true. So I first was introduced to the eye, I guess you could say, as a potential career choice in high school. So we were doing dissections on cow eyes. And I remember just getting in there, peeling things apart, looking at the structure of the eye and just being absolutely, amazed at how something so complex would function perfectly to create vision for people and animals. And it was basically that was my introduction to, wow, the eye is really cool, and maybe I want to study this more. So kind of a unique, I guess, but then once I got to job shadowing a couple optometrists, I really fell in love with the patient interaction and, getting to see everything so close up. That was just it really lit the part of my mind that likes to see the structure function correlation. So I never really fell away from it after that.
And then I think you kind of parlayed that. My next question was going to be, about you being involved in triage and handling acute problems, but it seems that you're still interested in that, that dissection, that physical, I'm sorry, I'm gonna start that again because I goofed up there. So it seems that you've really parlayed that with your interest in triage and acute problems on top of just becoming an optometrist.
Yeah, definitely. That sort of, I guess, fell onto me at the University of Iowa first, where it was always an interest of mine, but I didn't know if I would really be cut out for it necessarily. In residency, we saw a ton of stuff, and a lot of it was in different subspecialty clinics that was no longer in the acute phase, but now we're in the chronic disease management phase, which taught me a lot about how things look later on. But I wasn't as familiar, comfortable with what's going on with the initial diagnosis, because that kind of sets the whole pathway. And one thing that's really great is that now we've got our residents in the ER with us, our optometry residents, and so I get to teach them what I didn't necessarily learn at my residency. So it's pretty high volume. But to go back to starting at Iowa, when I interviewed there, I think they were saying, okay, well, we have a spot for an optometrist. We're not sure where we want to put you yet. And they kind of asked me what my interests were. And I guess I would give this, maybe this recommendation to new grads, and just be open to what you can do with your career, because I basically went into that interview and sat down with, someone from retina, someone from cornea, someone from glaucoma, and kind of went through all the services. And barring two subspecialties, which might remain nameless unless you convince me to give them up, I basically said, yeah, I love glaucoma. I would, I'd be happy to manage glaucoma and the non-surgical cases, and then, work back and forth closely. I also said to cornea, I love cornea, and, I'd love to watch transplants and manage those, and long-term, OCP, or, these crazy dry eye cases like Sjogren's. And I kind of went into each part of my interview being open to that. And I wasn't lying. I really do like everything. The only ones I didn't offer that necessarily were to neuro-ophthalmology or pediatrics initially, which now I actually really like neuro too. But it was kind of interesting. So I came into that and they said, we have a good place for you. The cornea department was like, we'll definitely take an optometrist. We could use that. And it worked very well to be kind of, I guess, folded into that service, because obviously we all know that optometry and cornea and transplants work super well together. And then the other part was, we need someone to take on this triage service that we're trying to start, or that it was, kind of morphing into something different. They were getting a lot of calls that were interrupting clinic flow for patients needing to be added on. And they said, why don't we just have you take all the add-ons? And so I was doing, whatever would come in, whoever would call in with an acute problem. I was taking patients transferred from the University of Iowa's ER. They would basically send them over to our clinic. I was also doing some consults for some of the inpatients who were more ambulatory that could be wheeled down to the clinic because it's connected to the hospital. And so it was really a great way to see a lot of acute disease and still have, every subspecialty behind me being very supportive. So I never felt like I was really out on a limb per se,
That's great. That's great. It sounds like you fell into that niche and it was a great fit. I was looking at also at some of the articles, then not only being a clinician or being a great clinician and having these great experiences, but you then parlayed that into a writing career. One of the articles I wanted to ask you about was the 6 OCT pitfalls to avoid. How many of those pitfalls, off the top of your head, can you share with our viewers?
Oh my gosh, that was a long time ago. You went back to like 2016, I think, right?
A long time ago. That was like yesterday for me.
5 years, man. I just graduated.
Well, you don't have to quote the article, but what are some pitfalls of OCTs that we want to avoid?
Yeah, definitely. So I think one thing that people don't give enough credit to is the choroid. So that's always a hot topic whenever you're at a lecture that talks about OCT, is that people will always get, immediately drawn to the retina. And I think everyone starts at like the RPE and then the foveal contour. And we just immediately look at those. Those are two very recognizable features. But people don't think about the choroid underneath. Now, if the choroid is thick and it's a young patient that has kind of outer retinal changes, it might be something like chronic, central serous. If you see, the macular neurosensory detachment or a PED, it's a lot more obvious. But, it kind of looking at the other parts of the OCT that you don't normally give credit to. On the same line, if you think about, certain cases that might look like something but really aren't, I think a lot of people get kind of tripped up on maybe things that look like cystoid macular edema. So, we can see VMT that has, traction on the macula, and that's not going to respond to anti-VEGF agents, obviously. So a lot of times you can just monitor those or just watch those. So another thing that people get tripped up about looking at OCTs would be things that look like macular edema that really aren't. So off the top of my head, the things I would think about would be something like vitreomacular traction, where the treatment's totally different, right? We're not sending that patient out for an injection, or we're not, trying steroids and NSAIDs for them. That's more something we can maybe watch and see if it resolves with time. Other things like outer retinal tubulations and chronic atrophy of the outer retina and the RPE, and then things like MACTAL, so macular telangiectasia, has some pretty classic findings on OCT that I've seen get referred in for retinal edema and non-responsive to drops and things like that. So yeah, there are a lot of things that we can kind of up and dig around at the OCTs.
You did good. I think you got 4. That's enough for me. I'm impressed. From 5 whole years ago. I was really drawn to your knowledge of trauma and your experiences that you've seen in the ER. I know one of the controversies in acute care of the anterior segment has to do with hyphema and the medical management. Can you update us on the current standard of care, or anything that people might want to know about about hyphema and treatment?
Yeah, definitely. So hyphemas, I think, are one of those things where the diagnosis is easy, but the management can be variable depending on the patient. So typically, the first thing that you have to do is, of course, try to rule out any other damage or trauma to the eye. But after you've pretty much decided, hey, if it's just a hyphema, you still, treat that. Typically, you'll be treating with cycloplegics and topical steroids. Now, I think a lot of the the discussion lies around what we need to do next. Does this person have to be on bed rest? Does this person have to, stop their aspirin or their blood thinners? There's a lot of questions around those. And I think a lot of it's common sense. For me, if I have someone that has a small layered hyphema, like maybe a grade 1, or especially, just at the bottom starting to layer, I'm not going to say that person needs to be on bed rest. Quiet ambulation is good, but being reasonable about it. Now, if you have someone that has a larger hyphema, someone who's more high risk, like a child, who might not necessarily understand that they need to take it easy. You have someone who has sickle cell, for example. Those patients you need to be a lot more cautious with, both in, what they do around the house, but also making sure frequently, because I've seen a lot of cases where, they might not have had an elevated IOP at day 1, but they come back day 2 and suddenly it went from, 19 to 35 in one day. And so in those patients, we need to be very aware, first of all, if it's a patient of Middle Eastern or African descent, checking in for a sickle cell prep, to be sure we know that if they have, a sickle cell trait, or if they're a carrier of any kind. Because that will also affect our management in the way that we watch them even closer. We have them under a microscope, because those are patients who are more susceptible to severely high intraocular pressures. But yeah, there's a lot that kind of, I think we don't always understand fully. And some of the research, they've done that analysis of our strategy for treating these patients, and they found that a lot of the things that we've always classically done don't necessarily make an impact like we thought they did. And things like, people ask all the time if they should stop their blood thinner. And the general recommendation, I think, is not to stop it, because by the time you have someone stopping their aspirin, for example, it's still going to be in their system for a long period of time, probably longer than the hyphema. Right. The other things, people are on Plavix or medications that are life-saving, and we certainly don't want to stop those. Just in case, the IOP were to elevate with a worse bleed or something. So we do have to manage those. We have to be aware that they're on blood thinners, but we wouldn't have to stop them.
Yeah, most of the decision making around that is based on the results of controlled clinical trials. That's generally how decisions get impacted when there's standard of care or changes in standard of care. But as far as open globe injuries go, there's not a lot of data like that. How are decisions made in open globe injuries without that real controlled clinical studies backing it?
Yeah, so I would say for me, my experience with open globes is still somewhat limited. I mean, usually what happens when an open globe comes into our ER, they are already triaged by the nurse and seen by a second nurse who's done their entrance testing. By that point, they've already been labeled as an acuity level 1. So for me, an acuity level 1 is either an acute angle closure, a patient who has an open globe that needs surgery. And those are the main two, and sometimes the MAC on RD that will come in would be level 1. And those are basically ones that, as an optometrist, I'm not able to fix that or address their concerns on that day. So the general standard, though, with open globes is, they can still come into the office, and I think we've all probably had, maybe experiencing a couple come in that you weren't expecting, and they pop in the middle of your clinic. Really the main goal of an open globe treatment is the first day trying to get the globe closed and keep the eye from getting infected. Those are like the top two things. And so the patients usually undergo, at least in our facility, they undergo a CT of the orbit so we can assess the globe fully. We will go ahead and usually assess their tetanus status if it was something dirty or metallic that might lead to a tetanus, a bacterial infection. Oftentimes they might get oral antibiotics. Not always. It depends on the site of the globe rupture. But after that, really assessing, for the outcome, the study that I think about the most that kind of guides our decision making as far as what to tell the patient for visual recovery would be the ocular trauma score. So you can always reference back to that. But the general thing is, if it seems like it's worse at the beginning, it's probably going to be a worse recovery as far as vision is concerned. And then people get kind of, I think, are surprised that when someone would come in with, a large, foreign body through the cornea, for example, that we're not necessarily going to, take the foreign body out, do a nice, penetrating keratoplasty and close it up, make it look real pretty. The initial surgery is just to close the globe. So if that can be done without going through a transplant, it's probably better that way, so that there's the least amount of intervention at the beginning. And then after that, you see what the outcome is and then what needs to be done after that.
It's amazing like that you're dealing with this stuff, but 90% of optometrists or maybe more would never even consider optometry or would never even encounter. So it's fantastic. Do you on the tail end of that question, you've heard about the Cornete corneal implant that just came out, the biomimetic cornea? Have you heard about that?
I have to say, I think I saw it pop up on my feed at some point, but I haven't looked into it myself. You can tell me about it.
Now, but they now have this biomimetic implant that is beyond trials now. I think in Israel, and I think that's going to change the game for a lot of the trauma. But again, we'll wait. Your next time we're going to have you back hopefully, and at that point you'll have some experience with it, and you'll tell us all about it then. One of the things I saw that you write and lecture on a lot are orbital disorders. These are some of the most scary things that walk into an office, or especially in an ER, of course. Can you tell us about a particularly daunting case, any kind of orbital disorder that comes to the top of your head that you dealt with?
Yeah, I mean, there's quite. I actually just put together a lecture, and so the first one that comes to my mind is that one, but I'm not going to do that because I might be giving that later.
Good.
I think, one of the cases that sticks out to me is a gentleman probably in his 70s, and he came in with diplopia, swelling of the eyelids, some pain and discomfort. And he basically walked in, and I immediately saw him, and I thought, okay, this is probably a case of, IOI or idiopathic orbital inflammation or something, because the globe itself didn't look hot. The bulbar conch was not super injected, but he had a lot of inflammation around the eye. And then when I was doing his motilities, there was some restriction. I checked his exophthalmometry. He had, proptosis on that side as well. And so, immediately you're thinking of, is this an infection like orbital cellulitis, which, it didn't seem like it based on his review of systems. is this a tumor or mass? And so you always ask the question, if someone's got proptosis, do you have a history of cancer? Because it could be a metastasis from somewhere else. Then I was thinking, is this an inflammatory disorder? And, more likely the inflammatory disorder would be more common than an orbital met or an orbital cancer. That's kind of where I was going along those lines. But either way, to figure it out, the patient got imaging. And that is one thing that is really awesome that we have the ability to do at our ER is we're actually fully stocked and loaded with an MRI and a CT in our basement. So if we need an MRI for someone, which is every single day, pretty much we're using it, we can just send them downstairs and be like, oh, we'll see you back when you get your scan done.
Sure makes things
so they leave
easier.
Yeah, absolutely. We don't have to deal with prior authorizations and things like that.
Right.
And he basically came back, and I was pretty surprised at what we saw. And he actually ended up having a large mass in the orbit, like very large mass in the orbit that was thought to be probably some tumor, cancer of some sort. And so the crazy part about, and I didn't say this earlier, was that he was actually at the hospital. He was only in Miami for a vacation. He had gone with him and his wife to visit from Texas. His wife was currently in the hospital because she had slipped and fallen down a flight of some marble stairs, slipped a disc in her back. So she was actually admitted already, and he had been visiting her. It was actually pre-COVID. So he was with her, and he thought, as he was there, for a couple of days, his eye started to bother him more. So he came in. So he walked himself over to our clinic. And so I'm like, this is the worst vacation for these guys. She basically broke her back, and then we diagnosed an orbital tumor on him. So he ended up getting treatment and follow-up closer to home, which was good for him. But it was kind of a scary and very unexpected, diagnosis. And that was within my first couple of months starting. So.
Wow. And now they're dealing with COVID. So things did get worse. I'm sorry to hear that, but it got worse for all of us.
Yeah.
So
yeah, definitely.
You mentioned that one case you weren't going to talk about. It sounds like you're going to put that in a paper or a lecture. What else is next from Dr. B? What can we look forward to in terms of lectures or publications?
Well, if you can look forward to it, that's great. That makes me feel good. If you're dreading it, there's still some stuff down the pipeline here. I'd say basically today was, the day for Academy submissions for lectures. So, you throw your name in the hat for a couple of those. One talk I'd be really, really stoked about is a talk that I've submitted with a couple of other doctors who are all way cooler than me. So John Gellis and Scott Hausworth and Aaron Bronner. So we've teamed up to put something together, and it would, whenever, we'll give it at some point. I don't know if it'll be Academy, hopefully, but it'll be entertaining. So that's one, writing a couple pieces about, pain in the eye and sources of pain, from the orbit and the eye itself, which is kind of a cool topic or a cool lens to look at it through. Those are the main things. Yeah, that absolutely wasn't intended. Thank you for calling me out. A couple things.
So, and beyond that, we're going to wrap up soon, but I did want to bring up the fact that you have a wedding coming up, and I was sorry to hear that you had to postpone it. Are you ready? Is it going to go off this time? Let's hope.
That's a loaded question. You know that. Well, hopefully. We're kind of, firing on half of our cylinders right now. I'm ready, yes. And I was ready last June as well. But yeah, my fiance is, he's actually in Miami too. He also works at Bascom Palmer. You met him when we were kids. Yeah. So he came with, and he's an oculoplastic surgeon, obviously. So he's got a lot of stuff going on. And, but basically we've tried to kind of hold the excitement back in case it doesn't happen the way we want it to. But yeah, it's going to be a go. I just don't know what it's going to look like. It could be just us two, it could be 30 people. I'm not really sure at this point, but
yeah, you might want to just invite the extra people who've been vaccinated at that point, just to fill it up, right? that might be something you could do to make it all right.
We'll see. Everyone just out, throw your card at the door, I guess. And no,
that's right.
We'll see.
Well, I'm excited for that. It was great to meet Andrew. He's a real nice guy. We had a good time there hanging out. want to thank you for being here today and tell you that I know you took time out of a busy schedule to make this happen, and I appreciate that. And I think the industry has so much to learn from you. You're young in your career, and you've got so much more to give. And I look forward to seeing you in 5-10 years from now, and what you're bringing to our education and to the journals and everything. So thank you, and I really look forward to the next time we see each other in person.
Awesome. I look forward to that as well. And I'm really thankful for the opportunity to be on this show. I didn't think I was as cool as your last guest, so that was kind of an exciting thing for me to be me to be invited.
I don't know. You're being modest. I think other people might think differently. With time, people get cooler sometimes, but that'll definitely happen to you. I got guests coming on, some of the names you mentioned today that you were partnering with, so we're excited for all of them. But you were particularly exciting because, again, the things you do are incredible. So thanks, and let's connect real soon, okay?
Yeah, looking forward to it.
Hi everyone, thanks for joining us here today on the Fluorescene show. Today I'll be discussing a case of normal tension glaucoma, which can be a little bit more difficult to manage compared to primary open-angle glaucoma. Before I get started, I do have a financial disclosure. I am a speaker for Aerie Pharmaceuticals. This is a case of a 38-year-old African-American female who was referred for a glaucoma evaluation by their primary eye care physician. This patient had denied any history of ocular trauma and denied any history of ocular surgery. She did report a family history of glaucoma with a grandparent having the disease. She reported that she was in good general health. Her only medical condition was a history of migraines and headaches. Patients entering visual acuities were 20/40 in each eye with her glasses prescription, which was -450 OU. Her IOPs were 12 in each eye, measured with Goldman tonometry. Gonioscopy revealed deep angles. Each quadrant was visible to ciliary body OU. Pachymetry revealed thin corneas in each eye at about 495 microns. The dilated fundus exam showed moderate cupping in each eye, as you can see on the OCT here. I graded the cupping at about 0.8 OU, and I noticed some superior and inferior thinning, as well as temporal peripapillary atrophy. The visual field here, as you can see, shows superior temporal wedges and inferior arcuate defects OU. At this point, I had diagnosed the patient with normal tension glaucoma, moderate in each eye. I had given her the options of selective laser trabeculoplasty versus topical therapy. The patient had elected for topical therapy. I initiated treatment with a prostaglandin analog, latanoprost, in each eye at night. The patient did very well with this medication. At her follow-up visits, her pressures lowered to 8 OU, which was the target pressure I had set for her in each eye, which was a 30% reduction. The patient's IOPs remained stable at the subsequent 4 to 5 visits, ranging between 8 and 9, and her disc evaluation and her visual fields were stable as well. Unfortunately, at the very recent visual field visit, her visual field in the left eye did reveal some progression. As you can see here, there was an increase in the superior arcuate defect, while the inferior arcuate defect remained the same. On the right eye, the superior and inferior arcuate defect were both stable with long-term fluctuation. At this visit, her IOPs were 10 in each eye, a little bit higher than the previous 4 to 5 visits. In normal tension glaucoma, even a 1 or 2 point increase in pressure can be significant. At this point, I had recommended intervention with SLT OU, starting with OS to better control her IOP fluctuation. The patient declined any sort of laser intervention. She was very afraid of having a laser done and had strongly requested to continue with topical therapy only. At this point, I had the option of adding a beta blocker in the morning, or adding a alpha agonist, BID, or switching to a fixed dose combination. I chose to switch her from latanoprost to rocklatan, which has latanoprost in it, and Ropressa. The patient did quite well with rocklatan. At her follow-up visit, her IOPs lowered to 5 and 7, 5 in the right eye and 7 in the left eye. Rocklatan can be a very useful tool in younger patients with busy schedules when you don't want to increase the number of drop bottles and when you don't want to increase the dosing. Rocklatan allowed for her to stay on 1 bottle only and QHS dosing only. Another benefit of rocklatan is that it can lower the IOP past episcleral venous pressure, which is typically between 10 and 8. The tarsidal component in rocklatan is able to get you past that floor effect, such as in this case here, when her IOPs were lowered to 5 and 7. So rocklatan can be a very useful tool in patients such as this, where their pressure is already really low and they're still progressing, and they decline any laser or surgical intervention. I hope that this was helpful. Thank you for joining us today. I'm Dr. Judy Hu, and I look forward to seeing you on the next month's segment of Who's Got Glaucoma. Have a good one.
Okay, I'm here today with Dr. Dan Twelker. Dr. Twelker graduated from the University of California, Berkeley School of Optometry in 1992. He completed a PhD in vision science at the University of California in 2001. In the past, he's worked in private practice and at the University of California, Berkeley. Since 2002, he's worked at the University of Arizona Department of Ophthalmology and Vision Science in Tucson as a professor of ophthalmology and as the site principal investigator of the CHAMP myopia study. While at the University of California, Berkeley, he won awards for his research, including the Harold Cohen Award for Best OD Thesis in Clinical Research and a Distinguished Service Award, a Mentored Clinical Scientist Development Award by the National Institutes of Health, the Minnie F. Turner Award for Impaired Vision Research by Pacific University, a prestigious William C. Ezel Fellowship by the American Academy of Optometry, and the Brian Holden Humanitarian Award. He's an author on numerous publications in the field of myopia and the pterygium. He's all over the place. Much of it is ocular biometry. And most importantly, he is now serving as the president of VOSH International. Now, that's some resume there, Dr. Twelker. Well, Dr. Twelker, welcome, and it's an honor to have you on our show. Your resume is impressive, to say the least. I read your work, and I went through your CV to prepare for today's show, and you've clearly defined your work around ocular biometry and related issues. Can you trace things back and tell our viewers where your interest in that came from?
Well, I was fortunate enough to work with Carla Zadnik and Don Muty, among others, and also Mark Bullimore, and my advisor for the PhD was Ian Bailey. So I just worked with such fantastic people that inspired me to better understand how we measure things and how we report them. And I also was very interested in looking at what causes refractive error, the origins of refractive error, specifically mostly myopia.
I know when we've spoken before, you're very passionate about retinoscopy, which is a topic we don't hear much about anymore. It's something that really makes sense to me now after I learned all that about you.
Well, I'm sure I'm preaching to the choir, but retinoscopy gives us more information than just about refractive error. We can learn about the ocular media. There are cases where someone comes in, they say, I've been to three people, 3 providers, physicians, they can't help me. And I do retinoscopy and I can see the warping of the image due to keratoconus, for instance. Or I can see the dark spot in the middle due to posterior subcapsular cataract. So I just find it to be extremely helpful. And, I see a lot of kids too babies and toddlers. And of course, in that case, it's absolutely essential.
Oh yeah, and that's a good segue into my questions about you were an investigator in the CLEAR study, which was the collaborative longitudinal evaluation of ethnicity and refractive error. And speaking about children, I get I speak about myopia control. It's one of my passions as well, and I get the question a lot on the importance of axial length as it relates to the practice of myopia control. There's so many factors like age and ethnicity and genetics. And as such, to date, as Kate Gifford said, there is no growth chart, even though I think everyone agrees it's very crucial to the art and science of myopia control. What did the CLEAR study tell us about the ethnicity part?
Well, there are certainly some ethnicities that tend to have certain refractive errors. For instance, I live in Tucson, Arizona, and the site here, we were working with the Tohono people. That's a nation of people, Native American people that live 70 miles to the west. And about half of the children that we saw needed spectacles for astigmatism. So definitely astigmatism is an issue with the Tohono people. And it's astigmatism enough to cause amblyopia. So it was pretty serious. And I'm still involved. To this day, we're doing a study now with very, very young children, looking at spectacle wear and compliance for toddlers. So
fascinating. So the conclusions around ethnicity were what?
That okay, I mentioned astigmatism for Native Americans, and that same issue comes through with our Mexican American population. That was in Houston. They were looking to recruit all. When you go to a school, we would recruit all children that were interested, but we would definitely target schools in Houston for Hispanic children, and then in Alabama for African American children. And each one of these groups did have some issues that were more particular to their groups. The whole study started in Orinda. That was the Orinda longitudinal study of myopia. But in that case, the group was, I think, 97% Caucasian or white. So that's how CLEAR came about, is they wanted to look at all the different groups. But in general, eye growth is very similar among all groups as far as, I mean, in general, kids' eyes grow fairly similar. Certainly the astigmatism could affect that growth, though.
Interesting. So the findings in that were really around astigmatism was where the differentiator lay.
And myopia, of course, looking at myopia, because, for instance, we noticed, we did a survey early on, and we noticed that the kids that reported spending more time outside did not progress, did not become myopic, at least not as early. And so we began to speculate or just wonder, why in the world are all these kids that are out there doing sports and soccer outside, why are they not as susceptible to developing myopia? So it was one of the early clues to look into light, the amount of light kids are getting in their eyes, and the incidence of myopia.
Excellent. Now you're involved in the CHAMP study. Can you tell our viewers about that?
Well, the CHAMP study looks at two different concentrations of dilute atropine, 0.01 and 0.02%, and then comparing that with the placebo. So it's the first, and it's also an FDA approval study. So it's the first study that will hopefully lead to, we're looking at safety and efficacy through the FDA, that will hopefully lead to an FDA-approved drop for children that have myopia where you are concerned about it progressing quickly.
Excellent, excellent. We're starting to see approvals in that field. The science is starting to result in products that are approved, which will help the public wrap their head around it and accept it as a science more now than speculation. I want to move on and talk about your ascension through the VOSH organization. And if you could start with your very first experience, your first mission. I think as a student you went on a trip to the Philippines, up till to your presidency.
Right. The first trip was in 1989. I was just ended my first year, and then the second trip to the Philippines was the next year. So I went 2 years in a row. The wonderful thing about those trips was that as an early optometry student, I got so much experience. We didn't bring autorefractors; they were too bulky and too fragile to lug on the jeepneys that we took around the small towns. But we just sat and did retinoscopy all day, many of us. And so I would do 50 to 100 retinoscopies in a day after day after day, and I became pretty good at it. And that's one of the great things about this organization is we invite optometry students. We give these optometry students, not only from the United States, but other countries, a chance to really get a lot of experience in a short amount of time. So after that, I just concentrated on working in private practice for a while, then doing the PhD, and then coming here to Arizona. And then eventually I was invited to do another VOSH clinic in Sonora, which is the state just south of Arizona, so in Mexico. And I just found myself getting interested and excited about doing that again. Let me jump now to the fact that I volunteered to go to Kenya to teach at a school of optometry in Kenya called Masinde Muliro University School of Science and Technology. So I taught there for a semester and then came back. And I think that's about when the organization, the leadership of VOSH started taking notice of what I was doing and said, well, he's been involved for this long. He went to Africa to teach. maybe we'll recruit him to get more involved in the organization leadership. Yeah.
Tell us about your most memorable moment during your VOSH experiences.
Oh,
sorry for the hardball.
Yeah. Well, I have several, but one of them, which just touches me to this day, is I was doing a clinic in Mexico, and there was a gentleman in his 40s in front of me who said that he wanted to work and he was trying to work, but he couldn't work because he couldn't see. And again, we're talking about retinoscopy. I bring up my retinoscope and start taking a look, and I couldn't see a very clear reflex coming through. And then we dilated the pupils, took a look inside, and he had dense cataracts. He had dense, I think it was nuclear sclerotic cataracts, which is a little early in age. But the point is, he couldn't see, and he was in tears. He just said, I'm trying to provide for my family. I'm trying to do the best I can. I can't see to work. So it just showed me the importance of concentrating on the two most common causes of preventable blindness. And we know what those are. One is, of course, cataracts, which I've just mentioned. But the other is uncorrected refractive error. In other words, the need for spectacles. And in VOSH, that's definitely where we put our emphasis. And we love to work with ophthalmologists, for instance, from C International, who do cataract surgery. That's a great combination of people working together to help prevent this blindness that is, again, completely unnecessary if we were just able to address it better.
That's really great. Have you seen or been exposed to Dr. Carey Gelb's Open Your Eyes movie?
No, but I'm going to check that out. Okay.
So it's exactly what you're talking about. He does a lot of things in the movie, getting the message to the public about optometry and the importance in general health care. But within the movie, he keeps going back to a family in Mexico with a gentleman, 100-year-old gentleman who had a very similar experience. A very vital guy, but he just couldn't see anymore. And they got him cataract surgery, and it's a great movie. I'll send you a link. But for anybody else out there who wants to see this, it's quite a work. It's optometry's real first movie that I know of. It's called Open Your Eyes by Dr. Carey Gelb. You can Google it as well and find out about it, but it's definitely worthwhile. So what is VOSH's mission of providing? I think they say their mission statement is providing sustainable vision care, development, and education. What does it mean to you, and how do you incorporate your experience in VOSH into your teaching?
Well, VOSH started out 50 years ago doing mostly just clinics for a short-term clinics for a few days to a week in mostly in other countries. We have which is still the foundation of VOSH for sure, but we have definitely moved into education because we realized that just spending a few days or a week in a town or a city in another country isn't really going to address the ongoing need for eye care 24/7 year-round that is obviously necessary. So the idea is now we do these clinics, but we invite students from the United States, students from other countries, and we teach. And that way the information that is learned in that week can stay in the country, stay with these optometry students when they graduate, and then they will be providing care in cities and towns in their country, not just for a week, but for year round. So that's the type of sustainable eye care that we are truly concentrating on now as VOSH.
Fantastic. Now, you're also heavily involved with the Jorge Rodriguez MD Memorial Lectureship. Who was Dr. Rodriguez, right, and tell us about that event?
Dr. Rodriguez was an ophthalmologist here in southern Arizona. When I first came here, he was working on a cross-sectional study looking at eye problems in the Hispanic community, the Mexican-American community in Tucson and south along the border in Nogales. So that's the Proyecto Ver study. So it really mapped out the important causes of eye disease and visual impairment in our Mexican-American community here in southern Arizona. Sadly, within about a year of me arriving here to work in the area, he was doing cataract surgery and he died from a heart attack during surgery. His wife continued, she's also an ophthalmologist. She has continued to stay active with our department, and we have a lecture every year at the end of the year. This is when our ophthalmology residents are getting ready to graduate and leave the program. So we have an invited speaker every year.
Sounds like he was quite a guy. And
yeah, very well. He was actually executive director of C International for quite a while too.
Excellent. How can somebody who's interested in supporting VOSH or getting involved, how should they go about doing that?
Well, the first thing, you can just go to our website, vosh.org, and you can just take a look there. The first thing you're going to see right when you go to that website is something's going to pop up on the screen. And we are still not, as an organization, we are not recommending that people participate in clinics quite yet due to the pandemic. We understand that in our offices and hospitals and clinics that as optometrists, we're working to help people in our communities. And even though there was a period of time back in, I think it was April and May, we even took a hiatus on that. But as far as VOSH clinics go, we feel like it's still we're not quite ready to guide people to do the clinics, given that some of these clinics are busy and people are close together.
Yeah,
so,
that makes a lot of sense. I imagine that everything that is every kind of mission has been kind of stunted by this as well.
Yeah, I can't predict the future, but now that we're vaccinating people at a pretty good clip here in the United States, I can imagine perhaps by the end of the summer or fall, we might ease up on some of our recommendations. But even now, we're recommending that people when they do start to do clinics again, just take all the precautions that we know very well in clinical practice about wearing a face mask and washing your hands, and social distancing, and also doing lower volume at this time.
Yeah. Smart. So we talked today a lot about your interests and your the work you've done in VOSH. Tell the viewers a little bit about your interests outside of optometry and vision science.
I love to get out on my bicycle. I have something called a gravel bike. So a gravel bike is a combination between a mountain bike and a road bike. So it has road bike geometry. It has those drop handlebars. So when you ride it, you feel like you're out on a road bike, but it has mountain bike tires essentially and mountain bike components. So here in southern Arizona, we just have hundreds and hundreds of miles of gravel roads, trails. Not necessarily real technical mountain bike type stuff, but just where you can get out on the road and go for miles and enjoy the fresh air and see the mountain vistas and our high desert vegetation.
That's great. That's the place to be a biker for sure.
I'm not the kind of person who's just going to sit around and not do much. I'm going to be out there when I retire. I'm going to be out there on my bike on those gravel roads. I'm going to be out there doing seminars, probably in Africa, South America, Central America, and now that we've got this Zoom and other platforms like what you're using here, it's great to be able to teach here from Tucson also.
That's fantastic.
And I'll definitely stay based in Tucson going forward. I really do love it here and love the high desert. And it's also a little less expensive to live here than some places. So I definitely plan on staying based here, but I sure enjoy traveling and incorporating my love of optometry and teaching and all that.
Excellent. Well, it sounds like you've got it all figured out, and it's going to be a great career into retirement, and where you're going to still be busy with all that stuff. Fantastic. Well, look, I want to thank you for taking time out of your busy day to talk to us and to let us know what you're up to and what you're doing. And, congratulations on your presidency in VOSH. I'm sure a lot of our viewers are going to reach out and look at the website and figure out how they can help and get involved. And I would love it if I could have you back sometime to talk more about these topics that are so relevant.
Thank you so much. It's such a pleasure, Alan. I really appreciate it.
Yeah, great. Be safe, and I look forward to hearing about your next trip, and we'll keep in touch.
Okay, sounds good. So long.